Hello, everybody. Welcome to Wednesday Lunch and Learn Special Speakers Series. We are very fortunate today to have Bob Conder with us. He is a PsyD who specializes in traumatic brain injury and concussion. He's been working for almost 40 years assessing and treating traumatic brain injury, and he has quite an extensive knowledge about the topic. Occasionally he posts things on the listserv. If you're watching, that kind of keeps everybody in line on this research and contributes resources and information which are invaluable to us all. And we're lucky to have him today to do a presentation. He's going to be part one of a two-part presentation. So without further ado, I'm going to let Bob take over.
Okay, thank you, Richard. Good afternoon, everybody. Thank you for joining us. And I want to especially thank Rob and Dr. Suter for giving me the opportunity to talk about sports concussions, an area I've been deeply involved in for many years. What I want to do today is present the state of the art in understanding research and data involved in sports concussions and how it may apply to your understanding of the patients you see in your office. As Richard mentioned, the talk is in two parts. Today involves the neurobiology and neuroscience, as well as some of the controversies involved in understanding concussion in general and sports concussion specifically. Next month, we'll talk about different biofeedback and neurofeedback approaches we found helpful in our clinic in working with athletes and other professionals, such as commercial pilots who've had concussions. So let's jump back in. Sorry, I couldn't start this without showing off my beloved Tar Heels, and that's my daughter there. Conflicts of interest, I really have no conflicts to declare. I did get free shipping from Thought Technology once and a free headset from Muse from Beta Setting. All I'm selling today are ideas, and to me, ideas have more value than commercial products. And this is some of the overview and some of my biases. You're going to see is I like sports. I like collision sports. But I want people and kids to play them healthy and safely. I also want to promote healthy physical behaviors that are good for concussion recovery and cognitive brain aging throughout the lifespan. I worked for over 10 years with the Carolina Hurricanes as their concussion specialist and part of the National Hockey League concussion program. This was our team in better days when we won the Stanley Cup, which is the Super Bowl for hockey. If you're not a hockey fan, I'm sure Martin and the others in Canada are good hockey fans. And the guy holding up the cup, Roddy Brindamore, now is our coach, and the team is on a rebound. It's amazing working with hockey players, some of the most incredibly elite athletes you'll ever work with from a physiologic point of view, because they're not just doing aerobic metabolism, they're doing anaerobic metabolism. They're working so hard that their cells don't have time to metabolize oxygen, but I worked with them for 10 years. I still work with this team some, the now North Carolina State University football team, another red team. Some of those guys on there are doing heart rate variability training with me for concussion rehabilitation. And it's different. College football is different, but still high velocity, high impact sport. And this team has done really very well this year with no help from me, but last week rated number 14 in the nation. But this is really what I love here is high school football, especially this. This is my son's team. This is from about 8 years ago. And this is sort of eastern North Carolina, where you can drive your pickup truck up to the side of the football game and tailgate and have a good time. A lot of people say, you're a neuropsychologist. How can you let your son play football? Well, Bobby started playing sports probably when he was 2 or 3 in the YMCA and recreation and church leagues. And when he was about 12 or so, he said, hey, Dad, I want to play football. I said, Bobby, you're really a good soccer goalie. He said, yeah, but I want to be with my friends and I want to do this. And, I come from a long line of football players. My dad played football for Army in World War II. His brother was a starting quarterback at a couple of different universities. So I said, okay, Bobby, if we're going to do this, we're going to make this the safest possible program that can be out there. And that's him, that little guy right in the middle of the scrum there. Number 11 is a linebacker and a tackle. He never got a concussion playing football. He went on to Chapel Hill, was an honor student, got too small to play college football, but was injured more with intramural sports, and recently graduated with a master's degree in accounting, and is working for an international financial concern. So I followed a lot of these guys that are his friends and other people from the team, and they've done really very well. 2 of them went on to play college ball. Most of them have been in business and executives. And when we get to the second part, we'll talk about number 6, who had a very severe concussion. It's actually first game of his varsity football career, and now he's playing for academically advanced school, neuroscience pre-med major. So what we tried to do was, and then I have to put this in, if any of you know NCAA basketball and the legacy of Coach Dean Smith, a wonderful person on the court and just a Renaissance man, very socially progressive. But I was concerned about a concussion in 1994 one of our players got in the NCAA playoffs. Up doing it was a layup about 6 feet off the ground, getting ready to dunk the ball, and he was clipped by a Boston College player. Came down, hit his head, had obvious concussion. The BC coach said there's nothing wrong with him, and we got knocked out of the playoffs. And I wrote Coach Smith, and we actually got that changed to be a flagrant foul, and something that's now really guarded against in basketball. So you can get a concussion in any sport. Let's start with the definition of concussion. People say, what is a concussion? Is it a head injury, a brain injury, etc.? Every 4 years, the International Sports Conference, the Concussion Study Group, gets together with world experts and develops these consensus definitions. Last time was in Berlin, before that 2 times in Zurich, then Vienna and Prague. And in the Berlin conference, it was a revision of the previous definitions, but basically this is the worldwide consensus definition. A concussion is a traumatic brain injury caused by a direct blow to the head, face, neck, or elsewhere on the body, not necessarily the head, with an impulsive force transmitted to the head that is shaking. It results in a rapid onset of a short-lived impairment of neurologic function that resolves spontaneously. However, in some cases, signs and symptoms may evolve over a number of minutes of hours. That is, there may be a delayed presentation. This I put in red because this is a new change and shows, I think, a better awareness of the literature that's out there. Neuropathological changes may occur, but initial presentation is functional rather than instructional. As such, no abnormality is seen on standard neuroimaging. So anyone who does concussions, whether they're Australian rugby or English, Italian football, or American or Canadian football, will work under the standard definition. I want to spend a lot of time talking about kids because right now there's a lot of concerns about kids playing contact or collision sports. And I want to try to show some of the data of how childhood itself is risky business, but also try to inject a little more reality in this. You can imagine the youngster on the left doing algebra and calculus, his head's hurting, and how that would feel, especially after a concussion. I think the guy on the right is a victim of too much social media. All right, there are 45 million kids in the U.S., and this is data that comes from the CDC Center for Disease Control and Prevention in Atlanta. 45 million kids and adolescents playing organized or recreational sports, and an estimated 1.6 to almost 4 million youth sport and recreation concussions a year. And of those, most are not organized, as the disorganized sports, if you will, with about 300K coming from organized sports. Here's my bias, and I'll fully admit it bias. Sports provide positive intellectual, physical, and social development. And as I mentioned before, there's this pushback against kids playing contact sports that seem to be driven by fear and anxiety, and perhaps even some hysteria. To me, EDD is more of a problem right now. Exercise deficiency disorder versus ADD. It leads to chronic health conditions, depression, and isolation. Right now, 20% of the 66% of the American population over 20 is overweight, with over a third being obese, and a fourth of the kids between 12 and 19 are overweight. And this is old data. This 2015 data. So what happens with this with these early onset conditions such as obesity, heart disease, diabetes in childhood, lead to problems in middle age with greater heart disease, metabolic syndrome, cardiovascular disease, and the data is coming out repeatedly that this situation in middle age is a predictor of early dementias in the 60s. So got a problem with that. Again, cardiorespiratory fitness is really correlated with academic performance, not so much muscular strength or flexibility, but the cardiorespiratory fitness. And let's talk about the problem with pediatric brain injury, because there's a lot of this going on. 10 to 14-year-old boys and girls have the highest rates of sport-related TBI ER visits, and there's actually a surveillance in the sense of a tracking system nationwide in the U.S. that codes every ER visit by age and diagnosis. So we've got a really good data set with this. So the 10 to 14-year-old boys and girls have the most highest level of sports-related visits, but the most common cause is bicycling, then football, then playground activities, basketball, and then riding ATVs. And then even if you look at the whole age range from 5 to 18-year-old, you're still bicycling, football, playground drops to number 4, but basketball. This is really a busy slide, but you probably can look at it with the PowerPoint. It's a table of almost any diagnosis at the ER for adolescents and kids. And again, the bicycles. That's why you really need to have a really good bicycle, teach bike safety, have bicycle helmets, but then followed by football, then playgrounds. And some of you, if you're an old timer like me, can remember or just look at playgrounds now and see how they've been engineered very differently to be much safer than they were, you know, even 10, 20, 50 years ago, 100 years ago, that they were, you know, kids flying off of swing sets and monkey bars and things like that. But you can get a concussion doing almost anything. And then basically the biggest risk factor for getting a concussion is being a kid. And some of that comes from lack of coordination. Your head is a little bigger than your body. Your balance is off. And there's really no frontal inhibition. The frontal braking system is not kicked in yet. Now, this is what sort of concerns me and shows some of the change in participation in youth sports for a 5-year period, and the 2014 is the last data we have. If you look at that far right column, just a big drop in almost all but a few sports. They're a little bit esoteric. Ice hockey, the actual numbers sometimes are not that great, but if you look at rugby, 100% increase from 150,000 to 300,000. The interesting thing about rugby, if you've ever watched it or played it, you don't wear helmets and pads, but there are fewer concussions by a manyfold in rugby than there are in American football. Lacrosse seems to have become more of a sort of a status sport. But I think one of the things that concerns me is that overall there are fewer kids playing sports. And some of that is driven by the need to do well on standardized tests in class. So schools have actually stopped gym classes. And again, I'm saying this early childhood activity as being a precursor not only for good brain and heart aging in young adulthood, middle age, and older adulthood. And just to drive home a point again, we've got this broken down. Again, boys will have more concussions than girls, but the interesting thing is that girls, while they have fewer, tend to have a more prolonged outcome. There's a lot of possible reasons for that. Girls actually have a thinner skull, and then there are the hormonal changes in adolescence. It may have weaker necks, and some of this I'm talking just from a sports part of view. When I worked a lot with the Finns, the hockey players, they would say, yeah, we do a lot of neck bridges in Finland. We have fewer concussions because we have stronger necks, and there's some validity to that. But basically the problem is that girls tend to have more prolonged or refractory problems with migraines. My wife is a pediatric neuropsychologist, and a large part of her practice is working with high school, middle school, soccer, lacrosse, and volleyball players with this post-concussive migrainous situation. Let's talk about concussions. Concussions have been around since we emerged as a species and started walking upright. If you think about it, it's a lot easier to get a concussion as a biped than a quadruped. The quadruped's got a little more balance, it tends not to fall as much. There have been reports of concussions in ancient Egyptian and Persian writing, as well as in Greek writing. And in the modern day, around the 1920s, this entity came from boxing called dementia pugilistica, and now is felt to be the basis for CTE, chronic traumatic encephalopathy, that we'll get back to in a minute. The interesting thing about studying concussions is that it's a lab. The SLAM model that my colleague, Dr. Jeff Barth, recently just retired, University of Virginia Medical School, the SLAM model, sideline laboratory assessment model, it gave us a lab in vivo to see a concussion, to know it happened. And Jeff was the first to do sideline neuropsych testing with the UVA football team until the coach made him start, Coach George Welch. And Jeff said, why? He said, you're scaring my players. They won't hit as hard. The National Hockey League concussion program has been in place for 21 years. And I think it's we have one of the best ones there. It's managed by neuropsychologist Ruben Echemendia. Penn State, Ruben also works with the concussion program for Major League Soccer. And this actually developed when he was a professor, a psychology professor at Penn State, and Coach Joe Paterno came to him and said, hey, Doc, I'm worried about my players. Is there something you can do to try to see what's going on and how to help them? And as Ruben said, you don't say no to Coach Paterno. So it's a really good model. It's only been reluctantly accepted by the National Football League, and they've really fought it, unfortunately. And I think finally they're now getting the idea that concussions are a real thing and they have to be managed actively and aggressively. So what's the deal with the concussion? Well, we think when it says it's a functional and not a structural issue, with a blow to the head, there's a neurometabolic cascade that happens with a mismatch between cerebral blood flow, which is reduced, and glucose metabolism. When the brain's injured, it goes into this hyperglycosis and wants to eat up a lot of energy, and the energy is fed by blood flow. And so I'll talk some now and next time about heart rate variability and cardiovascular aspects of concussion. This mismatch really is what we think drives the symptoms from a central nervous system point of view. In this study, David Hovda, UCLA, which is still doing the primary, I think, neurobiology study of concussions, but he tracked the rat models, and these are rat brains. Then 7 days they were back to baseline, and this is where the initial sort of finding that, okay, 7 days are over, a concussion came from. But that was, 2001. Now we know a lot better, but it's still the same idea with this neurometabolic cascade. Another way to conceptualize this came from Paul McCrory, a sports physician in Australia. And if you know anything about Australia, they're just totally sports crazy down there. And he's been one of the leading people with the Zurich model and now the Berlin model. They postulate that sports concussions were minimal TBI in terms of a scale of severity. If you don't know about the Glasgow Coma Scale, I always say Google it. We don't have time to go into that, but it's a way of measuring depth of concussion using motor responses, eye-opening, and verbal responses. Most concussions are going to be in the mild part of the schema here, and the idea is sports concussions are minimal. This is a little bit of a busier slide, and it comes from the VA Department of Defense classification of severity. And going to this mild, moderate, and severe, that's divided up by the research, and this is just classic out of the research on traumatic brain injury in terms of the GCS, which has a maximum of 15, and Glasgow Coma Scale. And these are just research. You divide people by clinical symptoms to treat them, and also research to understand them. The thing that's really, there, get my mouse there. This is the idea of permanence. There's no question there's permanent problems from a severe TBI, usually someone who's had a loss of consciousness, and a lot of these folks will have positive findings on not just MRI, but CT, brain bleed, skull fractures. When I began my inpatient career working with TBI over 30 years ago, it was in the Department of Physical Medicine and Rehabilitation of the Medical College of Virginia, and you really had to have a severe or moderate for admission, for inpatient admission. And I've followed these folks, and some I've followed 10 to 15 years. They get better. There's the Glasgow Outcome Scale most people don't talk about, but there can be a good recovery from a very severe injury. Some of them are able to go back to work, go back to school. The moderate, the category in between, has a better outcome. But what we can debate, and what we've been debating for over 30 years, is there permanence in terms of neurologic dysfunction with a mild TBI? The moniker really is that there is no problems with a single uncomplicated mild TBI. The issue becomes okay, what if there are more than a single TBI in terms of the mild spectrum, and what if there are complications? But this is the one probably most of the patients that you will see, sorry, my cursor's not cooperating here, most of the patients you will see will be in the mild column. And I'm going to talk a little bit about drilling down and delineating the aspects of a mild TBI that can be seen as a prolonged post-concussive syndrome. This is the sort of the culprit here for mild TBI. The thinking is that it's basically an axonal injury, a diffuse axonal injury. So this is a very simplified motor neuron, but if you don't know what a neuron, this basically, here's the soma, the cell body. Information is transmitted electrically through the axon over to the axon terminals. Then there's a space, it's called the synaptic cleft, where the electrical impulse is changed into a chemical impulse, and it goes over from the terminal there to the dendrites. And that's the basic processor and communication system of the central nervous system. These myelin sheaths actually are cholesterols like insulation, but what we think goes on is this diffuse axonal injury is the primary anatomic substrate. And this is courtesy of Chris Giza, who works with David Hovda. Hovda is a neuroscientist. Chris Giza is a pediatric neurologist. And these are obviously invasive because they are taken from tissue that's stained and looked at under a microscope. So the concussion is thought to be from acceleration, deceleration of different areas of the brain moving in different directions at the same time, either adjacent or distant. There's some new research looking at the waveform. How often is this tissue shaking? And everything basically is a waveform, just like the EEG. These are mechanical waveforms with 30 cycles a second. You know, the brain is not solid. It's not like a muscle or a bone, but it's gelatinous. Remember as a kid, my mom would make Jell-O in a big clear glass bowl, either red or green Jell-O. And I used to like to take it, shake it, and look at it sort of vibrate. And that's basically what your brain does inside the skull. And you can see it go in different directions at the same time. When it exceeds sort of the tensile strength is when there is damage to the axons, or the branch of physics that looks at this as elastoplasticity. So it's looking at the limits of tolerance under a load without breaking. And on the QEEG, basically, you'll see this in connectivity and phase measures, which are felt to reflect underlying white matter conduction velocities. And they can be short axons or long axons. This is just a model on the right of intrahemispheric, the 7 centimeter versus the 28 centimeter. Could be the other way, posterior to anterior. And then we want to look at the intrahemispheric with all the fiber bundles, the axons going through the corpus callosum, this big collection in the middle of the brain that transmits information from left to right, as do the anterior and posterior commissures. So here's just some more work from David Hovda and Chris Giza showing a juvenile rat brain with the repeated TBI. And what you're seeing is greater inflammation, and the stain is indicating cell death, which actually is this. They're called bleeps, APB bleeps, amyloid protein precursor bleeps, with these pustules that develop on the axon and limit axonal transport of electrical information. Okay, this is one of my favorite slides, one of my favorite players, another one of the fins. sort of there's a jigsaw puzzle how he and this guy from the Caps, I forget who the guy from the Caps is, but Yoni's got him tied up. But a concussion, I think you may be giving him a concussion, can be any place, not just in the head or the brain, it can be the eye, the inner organs, the spine, muscles, and joints. There are 6 aspects of a concussion I'll look at. Neurochemical, which we really don't see in the office, we see the cause of this. Then vestibular, basically you have little gyroscopes in your ear, in your inner ear, that keep you upright when you're moving, walking, spinning. And after concussion, those gyroscopes are knocked askew. Oculomotor, basically your eyes have to converge on a point in space to read. If you get concussion any place, especially if you get hit in the back of the head where the occipital lobe is, it'll be a convergence dysfunction. This is particularly troubling for students when they have to like look at their desk to a book. Yeah, we're just going to ignore that, and then look up to the blackboard, and their eyes don't track. This causes some real irritability and fatigue. Then the neuroelectrical that you see with the QEEG or any sort of sorry, it's like spammers. The QEEG or any sort of neurofeedback measurements, even single channel. I do a lot of single channel CZ-SMR, and we can find that there pretty quickly. And then neurocognitive stuff, the traditional neurocognitive stuff, pencil and paper, such as attention, concentration, processing speed. And then psychologically, there's a psychological aspect which could be related to the neurobiology changes as well as pain. And then if a person has to sit out, they're not part of that team group identity, which is so important to a lot of adolescents. Here's a way in your office that you can document this, sort of backwards. The post-concussive symptom survey is out there in the public domain. There are usually 21 items that have been felt related to a concussion, and you just give this to the patient or the client and have them rated as a 6-point Likert scale. And I had a professor who actually had Dr. Likert, and that's the way he pronounced his name, not Likert. And you get it broken down to these 4 categories, and the ones in bold are the ones that are most problematic or most common within the category, such as headache and sensitivity to noise, difficulty concentrating, irritability, and drowsiness. So if you don't have that, I'll give you my email at the end, and I can send you a copy of that, or we can post it to the list. Okay, a lot of times folks will say, did I really have a concussion? I hit my head on the cabinet door or on the hatchback on my car getting groceries, or my kid hit me upside the head with a soccer ball when I wasn't looking. These on the left are the usual symptoms. There has to be a blow to the head or a transfer of forces leading to this feeling of being stunned, dinged, in the vernacular bell rung or woozy, which then leads to headaches, nausea, photophobia and phono, that is, light, and the light seems too bright and sounds are almost painful. The red flags that say you really need to go get some medical attention, and or vomiting, it's gross stuff, but it happens and can be related to brainstem injury, increasing confusion, deteriorating consciousness, a severe headache, behavior changes, lower extremity weakness and balance, and double vision. Not necessarily go to the ER, but call your family doc, go see your family doctor, go to urgent care. But those are red flag symptoms that say we need to make sure there's not something much more serious and life-threatening that's going on. Here's where we sort of get into a new change in terms of looking at recovery. If you think back to the neurometabolic model, it was a fairly linear model. You started here, in 7 days, things were fine. This is the idea that you're normal pre-injury. The problem is most of the athletes I've seen, like with some of the Hurricanes, that get their first concussion at 18, and I would say, how long have you been playing hockey? Well, since I was 3 or 4. When did you get your first concussion? Well, I was 4 or 5. So it may not be normal, but it's pre-injury at that time. Then there's a concussion, then there are the acute symptoms. And we used to sort of jump from acute to full recovery. Now there is this sort of window of vulnerability in which the person does fine on the neurologic exam, on the computerized testing, but there are physiological vulnerabilities going on. And this is introducing a lot of concern to some of us about the return to play protocol, especially for kids. So I wanted to see what the literature showed about this physiologic vulnerability period. in terms of the traditional stuff used to study concussions. We looked at balance dysfunction because balance testing, I call it the drunk driving testing. That's what I used to do on the sidelines with football players, finger to nose walking, tandem walking, like tightrope walking. A lot of the same problems when someone's had too much alcohol and a concussion, but that's really a quick way to diagnose a concussion on the sideline. But basically that clears after a few hours. The neuropsych test, the sideline assessment of concussion, can clear in a few days, or there can be long-term damage. The quantitative EEG, and I'll talk about really the one control study done, can show problems at 8 to 45 days or longer, whereas the traditional MRI and CT are negative. The evoked potentials, event-related potentials, especially the PB300 wave, can be abnormal up to a year. Steve Broglio, University of Michigan, found this, and in a way it's sort of a biomarker. It doesn't have the amplitude, and there's a longer latency. It doesn't happen at 300 milliseconds after experiencing an oddball stimuli. A PET scan for a couple of weeks, and it's probably longer. It's just that's the longest study. Magnetoencephalography, no one knows for sure. The procedure costs maybe $10,000 an hour, so you're not going to find that in a lot of studies. fMRI is really good, 13 hours. There's hypoarousal followed by hyperarousal or hyperactivity in the right attentional networks is felt to be a compensatory mechanism. And then the diffusion tensor imaging of the white matter is showing corpus callosum mean diffusivity during the athletic season paralleled with reduced verbal learning and memory. And again, the DTI is picking up a lot of the axonal damage that's back there. Okay, but the Institute of Medicine, it's a busy slide. Basically, they're saying, yeah, you know, these newer techniques show stuff, such as, you know, the SPEC and the PET, fMRI, DTI. It may be useful in the future, but right now they're not clinically validated. And then looking at electrophysiology, which is evoked potentials and QEEG, there's some consensus in the literature that both QEEG and event-related potentials can detect differences in performance and neural responses in concussed versus non-concussed student athletes in high school and college, even when the behavioral measures fail. However, these findings are true for a relatively small set of tasks that assess a limited array of cognitive abilities, and they recommend using a broader range of tasks rather than seeing the abnormality, the electrophysiologic abnormality itself is sufficient. And then this is you know, the fMRI network of what happens with concussion and sort of what you would expect. The frontal thalamic caudate network, decreased blood flow to the neocortical and limbic areas, but there's definitely something going on. Now this study, Bill Barr and Mike McRae did, they actually baseline high school football players before a season and then used a sort of portable QEEG called BrainScope that really just did the frontal regions, and then we're able to do this restricted QEEG within a day or so after the injury, and found really what you would be expected: increases in slow wave activity, decreases in beta, and general decreases across the frontal region. This is their metric. They had 70 EEG measures, and they put them together for one composite and took all the data and minimized it or reduced it to a Z of 0. It's a statistical technique that's a good way of looking at change, and we've done it with some other stuff. So basically, a Z standard deviation unit of 0 is normal. So then you have the baseline, then after injury, then you have one standard deviation different, then day 8 actually gets worse, 1.5. Then by day 45, they're saying, you know, there's no group differences, but there certainly were individual players within there who still were problematic and had a problematic or pathological QEEG. The thing, you know, the problem with post-concussive syndrome and all the post-concussive syndrome surveys is that it's not a unitary syndrome. There's no one symptom in and of itself that is not shared with other disorders such as PTSD, generalized anxiety, depression, and somatization. So what you have to do that makes it challenging and fun is really a biopsychosocial evaluation of each person who comes in. Premorbid medical and psychological factors of the child and family, especially history of migraines in mom, maladaptive personality characteristics, especially anxiety, catastrophizing, neuroticism, poor pain coping abilities. Athletes in general are going to get hurt and have to cope with pain. Family dynamics. There's a case I can tell you, my wife was working with a high school guy, and there's no question he had a concussion. It was witness, was on the field. And all of his testing was fine, but he kept having all these symptoms, these subjective symptom reports. And finally she said, look, I don't get it. Everything is fine. It's doing well. Everything we're doing objective looks really good, but you're having all these symptom reports. What's going on? And he sort of hesitated and looked down and said, if I get better, my parents will divorce. So the symptoms, had a functional significance there that they were keeping the family together. So that became an issue to work on, and it may have been true, but it wasn't certainly a pure neurophysiological symptom. So in a way, when you see somebody, you've got to sort of think from the subatomic to the cosmic and consider everything within the hierarchy there. Let's just go to this because I'm spending too much time with this, but basically we'll talk about depression and how athletes view a concussion versus an orthopedic injury, anterior cruciate ligament injury. And this is Linda Mainwaring's data from Montreal Children's Hospital using the POMS depression scale. The interesting thing is they both get depressed, but after 10 days, the orthopedic controls have a higher level of depression and it lasts longer. And so this shows that these athletes, and these were Canadian hockey players, didn't really have a good sense about the seriousness of their injury. In the old days, ACL was a career-ending injury. Now it's a season-ending injury. And there's some data from Dennis Alfano in Saskatchewan. A lot of folks say, what's the magic number? There really isn't one, but the rule of 3 has been around for a long time. This is looking at college hockey players. And if you notice, the controls are non-injured. They're endorsing about 10 of the concussion symptoms themselves, and then he sort of does a two group of concussed with just one concussion, as opposed to a historical group with multiple ones, and they're really about the same. So after 3, you can see the number of concussion symptoms bump up. The same thing with the psych assessment screener. The non-injured college student controls are endorsing measures of psychopathology. So again, the take home here is that the symptom surveys measure just sort of normal things and problems college students can have. But when someone gets more than 3, and basically that's a misnomer because every concussion is unique because every individual is unique both in their physiology and their personality. So I want to talk about a couple of controversies here. I think all this has to be research-based. My background is traditional medicine. I've been in medical schools, taught in academic clinical psychology programs. And with that, we're very research-based, and the purpose of research is hopefully to get this scientific ground truth. It comes out of the scientific revolution from the medieval times to overcome prejudice, superstition, and mysticism. And with data, hopefully specifying accurate interventions to stop disease and increase human well-being. As I always told my students, one study does not make science. There needs to be replication, but it's hard to replicate almost anything. And you actually need to look at the original study. You've got to look at subjects, methodology, statistics, results, and know the shop. There's some labs that do great research and you can bet your money on them. It's just like saying, hey, I won't take my car to that shop, but this other shop does a great job. And then placebo, there's a big controversy about that. Placebo is actually positive and part of the treatment alliance, and you won't have as good outcomes basically if you don't have a placebo effect. And placebo effects have been shown in the middle frontal gyrus. The other take home here is that we've got a lot of resilience as humans. Again, we've been having concussions as a species, and we can withstand these inertial forces. It depends on if you exceed sort of the tensile strength of your axons and neurons. Kevin Kuskowitz at Chapel Hill put sensors in the helmets of the football team and found that some of the guys could get a concussion at 60 Gs, and some guys could take 140 Gs and not get a concussion. And the brain does have self-repairing qualities. What worries me is some of the stuff in the popular media is that we're really, makes us sound like we're really vulnerable as a species. And if everybody who'd ever had a concussion playing football or recreation, who is now in their 40s to 60s, had the kind of effects that the media is hyping, our nursing homes would be overflowing with folks like that, and myself included with my concussion history. All right, going forward, all three of these are affected, and all three of these are necessary for good cognitive aging. The CDC just changed the exercise recommendations Tuesday, but basically with 150 minutes of moderate for an adult, 300 for an older adult, you actually get therapeutic effects. The thing they added, I've got in red down here, is balance training for the older adults, because balance and falls are a real problem, but balance training really exercises the frontal motor fields, especially balance exercises like Tai Chi. And then what can happen on the left are all the physical health things. Basically improves your heart functioning, cardiac function, endocrine functioning. And then on the right, your psychological abilities and your cognitive functions, but also exercises normalizes the EEG. And I think this is fascinating because these are such diverse groups. On the left are healthy college students. They looked at individual alpha peak frequency that increased with what was called exhaustive, a really hard workout. And a lot of people say, well, I don't have time to go to the gym. I can't get my patients to go to the gym. So on the right, they looked at what's called incidental exercise, housework, yard work, caretaking. The average age here was around 65 or so. And at that age, sometimes you're having to take care of a spouse or a family member. And they just looked at different intensity levels and found that higher intensity correlated with less of the slow wave and more of the fast wave, as well as increases in cognitive processing. And here's just, a picture's worth 1,000 words. These are the top row is the active old people. On the bottom, the passive, you see delta intrusions by temporal, and then theta ditemporal, and then really a lack of beta. So sleep, basically, I think you're going to get the PowerPoint to this, but so I'm not going to go into everything because I want to cover all the slides here. But basically, there's sleep disorders. Narcolepsy, I've only seen that with severe head trauma, and particularly folks with skull fractures, incredibly disabling. You're sitting talking to them, and then boom, they're asleep. And there are recommendations for amount of sleep. The cool thing about this is it shows that REM sleep, we need REM sleep to help consolidate memory, rapid eye movement sleep. The first REM period starts about 90 minutes, and then we have them for every about 40 to 60 minutes. And as the night goes on, you have longer. We get a lot of folks who have early morning awakening from depression or anxiety, and they don't get this big chunk of REM sleep here, and they also have memory problems. So we work on sleep hygiene and sleep interventions with them. After, if you think back to that neurometabolic model, we want to look at food, not so much as diet, but a nutritional intervention. The MIND DASH diet, the dietary approach for sodium restriction, and the Mediterranean diet actually reduces the incidence of Alzheimer's. 30 to 50% has been shown on MRI to reduce brain atrophy over time. And some controversies, and basically second impact is so rare. I was really dismayed AAPP because this was used to describe any sort of injury within the same season, but it's a very specific and rare clinical syndrome, but it does go back to that period of vulnerability we talked about. The big one here is chronic traumatic encephalopathy. And there's almost, to me, and this is my bias, a media hype that anybody who's played ball or had head injury is going to have this. It's not true. It's real. I met Dr. McKee, the neuropathologist for the Boston University CTE group, who does the autopsies, and got to see her pathology, histology slides. And there's no question about it. The question is about the incidence and how it happens. Even what she said was the NFL guys that she did were some of the hardest hitters. They never came out of the game, and some of them were also using performance-enhancing drugs. anabolic steroids, which actually is neurotoxin. So there are two studies that have come out that have been really positive. The University of Michigan one, and talking about shops, University of Michigan Institute for Social Science is sterling. Found that lower levels of cardiovascular and endocrine disease, but the spouses of these guys reported higher rates of memory disorders. It's interesting. This study, 10% of the study is players from ages 75 up through their 90s. And then, so you're piggybacking on the sort of normal age-related changes that can happen then. And SUNY Buffalo, State University of New York at Buffalo, John Leddy and Barry Willer. So another lab, you can bet money on what they did. And this just came out last month, looking at retired NHL and NFL people, and on all these measures, no real significant difference when compared against non-contact college athletes. And so they're saying the risk of CTE is certainly not as great. And if you really want to read a very interesting book, this just came out a couple of weeks ago. Merrill Hodge was a running back in the NFL, had 4 concussions, actually had cardiac arrest after one of them. And he's written a book with a neuropathologist, also at BU, but contradicting the science that's coming out of the CTE study and seeing this as he calls it the plot to destroy football, a little dramatic. So I'm going to take a breather here. Here's a little comic relief. This took me a while to figure out, but I'm going to take a sip of coffee. So everybody who's got it, raise your hand. All right, everybody raise their hand. Now let's talk about this with implications for treatment. I see concussions as dysregulation. And early on, I started training in biofeedback in 1983 at a Veterans Administration Medical Center on hand-built equipment. And it was so cool back then. We had World War II and Korea vets who would come in, and we basically were doing temperature, EMG, and what we call in the old days galvanic skin response. But we didn't really know that we were working with them autonomically. Now we know the sympathetic nervous system is out of whack, heart rate and then cardiac cerebral perfusion are changed by a concussion, heart rate variability is reduced. As the more variability, the better, and temperature regulation, or the ability to regulate temperature to send to open up the pipes, basically the flexible vasculature to send pipes out to your extremities or wherever you need them. From a CNS point of view, going back to the coherence models, hyper or hypocoherence increases in slow wave, decreases in fast wave, and general decreases in the frontal regions. So the goal to me in working with patients is to teach self-regulation and self-efficacy. And I took this definition and modified it a little bit from Julian Thayer. Another shop, anything that Julian Thayer at Ohio State does, you can bet money on it. Just wonderful research. But what he said in terms of sort of an optimal performance was the flexible and integrative neural network allowing an organism to effectively organize emotional, cognitive, and behavioral responses in service of a goal-directed behavior and adaptation to the environmental needs. That's just a mouthful, just such a high-level thought that he has there. And basically, if you can do that, you're flexible, you're meeting the needs of the environment, you're organizing your behaviors, and behaviors are cognitive, emotional, and physical things that you do in response to a goal to adaptively satisfy that need in the environment. And the environment can be two things. It doesn't have to be things out there in front of your eyes. It can be between your ears. So the goals to do that are cognitive behavioral therapy, biofeedback, neurofeedback, increasing stress management skills, increasing pain management skills, helping develop proactive problem solving, reducing autonomic arousal and reactivity, and helping increase quick recovery from errors. That's especially true for athletes. I like to use the example of Tiger Woods with his return. He's if you're a golfer, you can appreciate this, but he's on a green, he 4 putts. if you're not a golfer, you may want to make one putt to get the ball in the hole of the green. He 4 putts, and he's got a quadruple bogey. He's 4 over par for that hole, and he's got to go to the next hole in the tee. In between walking from the green to the tee of a few yards, he's got to just dump that error out of his mind, because if he's still thinking about it, he'll fluff his tee shot or shank it a little bit. So that goes back to the flexibility to be able to do what you need to do at that time to solve the problem in a proactive way. Okay, and some sort of backing up again, maybe it's not just the concussion, because we're people. We have a history before we have a concussion. We grow up in a family that has issues. We may not all have the most of flexibility or resilience. There can be anxiety and depression, and anxiety seems to be the most common factor for prolonged post-concussive syndrome, for prolonging the symptoms longer than they should be, as well as personality characteristics such as rigidity and catastrophizing. And those can be, there's been 1 or 2 studies using cognitive behavioral therapy to address those cognitive distortions in post-concussion syndrome. Some athletes have poor pain coping abilities. Doesn't mean that you don't hurt, you don't tough it out. You want to be more dynamic. And then the family dynamics that I missed. And then outside of sports, the possibility of a secondary gain. That is, what are you getting out of this? You may see that more in litigation, unfortunately, but it's something that can happen. So to make it even more complicated, let's look at the military. This is a slide courtesy my colleague, Dr. Brian Out, the National Center for Veteran Studies, University of Utah. What we're all looking for, at least for us, I'm a cognitive guy. I don't really do behavior or emotion. That's my bias. It's like it's a neurologist I work with, and he looked at me one day and said, "I don't do behavior." So, okay, that's your bias. I do cognition, and what we're really looking for is cognitive performance and athletic performance, or optimal performance. I'm working now with commercial carrier pilots, folks who fly 737, 747, 77. You want them to be on the top of their game. So that's the outcome variable. All these things in gray in these boxes can affect that. Dehydration. Dehydration can mimic concussions, especially in younger athletes. Stress, sleep deprivation. We really disregard sleep as a healthy mechanism in this society. But you can have sleep problems again after a concussion. Motivation, some people are motivated. My major professor in graduate school said the study of psychology is really based on one principle, and that's the principle of motivation. And I think that's certainly a major one. I wouldn't say it's the only one. But then you add PTSD in, and soldiers who have not had an IED exposure or explosion. We haven't talked about that because that's different than the sports concussion, but it's a vasogenic pressure change in the head from the pressure wave from the blast that certainly can cause a concussion-like syndrome. But folks who've been exposed to these emotionally wrenching situations but not had the physical trauma from a concussion or IDD can still have the same symptoms. So it's a really, in a way, a fascinating differential diagnostic dilemma that makes our job both hard and useful, because most of the time when somebody comes in, it's not just purely physical. At least what we see is the other things going on. It's a concussion with some anxiety, maybe some boyfriend-girlfriend problems with mom and dad, academic performance has changed, and these really high-achieving kids who are in advanced placement classes and really need to do well in their AP exams so they can do well in their SAT and get into the college of their choice. So the basic protocol, though, to sort of get to the nitty-gritty, if there's someone that you think has had a concussion during play or practice or elsewhere, but especially during play or practice, remove them immediately, take them out of the game. Have them evaluated by an athletic trainer or another qualified health professional. And this is usually on the sideline, or you take them back to the locker room away from that. If they fail the sideline exam, then refer them to a appropriately trained healthcare professional, and they shouldn't return to play or practice, either one, until cleared. And there's a 5-day graduated exercise protocol we'll talk about in the next time. So here's the mantra: when in doubt, sit them out. And I know there's some kids that have been really ticked off at me because I pulled them from Friday night football games, and that's, in America, it doesn't get any better than high school Friday night football. And that's their holy grail. And sometimes you pull them and they're really upset, but it's better to err on the side of caution. I don't think there's any caution at all with these hits. This is courtesy of my colleague Frank Webby down at Florida Institute of Technology. Frank's a neuropsychologist as well as a soccer coach and a soccer referee. But just think of that: when in doubt, sit them out. And I want to thank you for this part. Here's my email. If we don't have time for your question today, please email me, and I'll try to answer or pick it up or put it on the list. And I have to sort of put this in over here. This is the beginning, maybe even the peak of my football career. Christmas 1952. That's not the way you wear a helmet. Like I say, my dad played football for Army in World War II. His younger brother was starting quarterback at East Carolina and South Carolina, and I was supposed to be a Heisman Trophy winner. And when you put a lot of pressure on a kid, how kids get, I ended up running cross country. I was just a lousy football player. But I did, people will say, well, you trivialize concussions. Well, when I was 9, I was hospitalized with a moderate pediatric traumatic brain injury from a fall in a house, ADD kid, long story. Basically, I was in a house under construction. The last thing I remember is reaching for a light switch in a room. Well, it was where the stairs to the basement were supposed to be, and there weren't any stairs yet. So that was a good one. And then some, recreational football, bicycle wrecks, became a rock climber in college, a couple falls down the rock. And then the last one was a car wreck at 57. And that's been a little over 10 years ago. So I've certainly had my history of concussions. I'm 68, still running practice and talking to y'all today, and hopefully making sense. So Richard, that's it for this part, and I'll be happy to take any questions if we've got any time.